think that's the hardest part.
Yeah.
You know, because when we are not from Australia, you rely on being able to travel just to see your family or your friends. So I think it's going to be a little bit tricky.
This is the hardest part.
Yeah.
Otherwise, as Nina said, we can go out. We are essential worker. You can still go in parks to exercise. If you have children like me, you have to go outside to breathe some fresh air.
True. Look,
So-
Luisa is saying that she can be the CEO of our fan club.
Yay!
You are officially named CEO, Luisa. Go for it.
All right.
All right, guys. So enough chit-chatting,
Yeah, enough joking.
enough joking around. Let's go into... Right now we are going to be serious because this is a serious topic, you know. You know that we always have tried to keep this very light because everything around the ADC examination is already too serious. But when we are talking about TG, we know that this is serious and that we need to know these things by heart and that we need to be able to do a very critical reading of everything that is written here.
I think it's also very useful for part 1 candidates. We won't go as thoroughly as it is required for part 1 because part 2 is not that picky on details. But still it could be very useful for part 1 candidates. So follow up with all these sessions and hopefully it can help you.
Yeah, definitely. So I think the first things that we want to talk about today, it's about what changes are regarding how you're going to manage acute dental pain and also acute odontogenic infections and salivary gland infections as well.
Yeah.
So we will try to cover these 3 subjects today just to share with you guys what is our input in these kind of new things that we have seen here. So, okay, let's start with the chapter that talks about the practical information on how to use drugs in dentistry.
Yeah.
So, what do you think, Rada, is the first thing that we need to address there?
Something that we spotted is they talk a lot about the bacterial antimicrobial resistance. So we had a previous scenario about this patient that has had a joint surgery, that she's insisting on having her prophylaxis, and then there were lots of debate whether it's okay, we can give her because she was used to it,
Yep.
or these other candidates like me. They were more strict. No, I'm not going to give you anything.
I'm with you in that.
Okay, great. So now they are talking a bit more about the antimicrobial resistance. They explain thoroughly in details what is the antimicrobial resistance. In the ETG, what is important to know is the box 5, page 20. This will help you to assess firstly how to explain the harms of the antibiotic therapy. So this will give you some content to explain why it's not good for you, although it has some benefits, like for infections, for instance, stuff like that.
Yeah, that box is quite important.
Yes,
because it summarized very nicely what things we can communicate to the patient. So the patient, like in the scenario that Rada just told us, can understand why is it that we just cannot just prescribe things for the sake of prescribing things, you know, and just because the patient thinks that the patient needs it. So this particular box is going to give you these 3 bullet points in order for you to be able to explain that in a possible case like the one that we just said.
Exactly.
Obviously, you need to translate this in simple terms. It's not that you are going to sit there and going to tell the examiner, adverse effects of antibiotics include diarrhea, rash, or more serious hypersensitivity reactions. Obviously, that's not something that you need to just spill out there, but you need to translate this in more practical terms. Exactly. So the patient understands that there's always attached side effects for every medicine. And in case of antibiotics, this is pretty much the 3 things that we can communicate to the patient.
Exactly. Even they have added a kind of program. So it's called the AMS, Antimicrobial Stewardship, to promote the optimal use of these antibiotics, to avoid the misuse or the overuse of antibiotics, to improve the patient outcome, and also the understanding why it's not good for them.
Yeah.
So I think it's a very useful paragraph in this chapter to explain and understand why from where it comes the antimicrobial resistance. Then they are talking a lot also about the antimicrobial hypersensitivity. First of all, so in clinic, in real life, we always ask the patient when they tell us about an allergy, how it came, what was the reaction, because sometimes some patient will think, I had diarrhea, I had this, but it's not allergy, it is a side effect. So they are confused with the side effects, adverse side effect, and the allergy. And it is written in TG that we should investigate, like you'll see in box 7, page 29, that we have to investigate about the allergy. What do they mean about allergy? Because the use of some antibiotics, some kind of antibiotics, are very beneficial, and we don't want to miss the use of these antibiotics particularly. So you have to know this box.
Yeah, I think that's
to ask
page 29, box 7.
Yes.
It says clearly there, questions to ask in an antibiotic allergy assessment. So if we put this in the context of an OSCE, if the examiner, so-called patient in that case, tells you that he or she has an allergy to, let's say, penicillin, then at least you should be able to assess the type of allergy, because it's written here in TG, that's your guidance. So you are going to ask the patient about the severity of the reaction, the timing, meaning how long after that patient took the antibiotic, got the reaction, and also if he has or she has used that particular antibiotic after that reaction back in time. So those three things need to be included if the patient is mentioning allergic reaction to any particular antibiotic.
So based on the information that the patient will provide, you will have this critical thinking that will lead you to page 32, where you have the several situations and how you are going to manage them. So this will lead you to prescribe the most suitable antibiotics based on the information you got from the patient and based on the kind of infection, for instance.
Yes, perfect. So if you guys have a new TG in front of you, or when you have the time to go and see it, that particular page 32 and 33 has a table that Rada just said, is pretty much a roadmap or your critical thinking, the things that you need to be assessing while the patient is telling you this timing, this severity, this medicine. So that's what you need to take in mind in there.
Then something about the non-steroid anti-inflammatory drugs, page 44.
Oh yes, well.
So you noted something else?
No. I think that's pretty much. So that's regarding the indication to prescribe a particular antibiotic, right? Just to summarize, because I think this could be a little bit confusing if you are just getting into the habit of reading this new TG. So basically here for antibiotics is like you have here how to explain the side effects to the patient, how to assess the allergy, and your roadmap to reach a conclusion about if that patient can be prescribed with this particular antibiotic. That's pretty much regarding antibiotics. The rest of the things regarding antibiotics is pretty much what you already know and have in the OTG as well. And then we move to the drugs that are used to treat acute pain in dentistry, right? So before we start with that one, for the people that just join us, just to tell them what are we doing today, Rara?
So today we are talking about the differences between the old TG and the new TG, what could be relevant particularly for OSCE scenario, but if you are preparing for part one, it could be also useful for you to get some information, maybe some precision to make things clearer. And we are going through the one of the first chapter in the new TG, and we're just comparing what it seems important.
Yeah, definitely. And with what Rada is trying to say is that important means those things that you need to pick on, yes, just to be more effective when you are doing your OSCEs.
Exactly.
So you don't have to wonder, do I need to ask this? Do I need to tell this to the patient? It's written there for a reason, and then you need to apply it.
So the acute pain management, so it starts from 43.
Yeah, 43.
And they are starting with non-steroidal anti-inflammatory drug used in dentistry. They added two categories of them. So you have the non-selective, which we are used to prescribe, ibuprofen, naproxen. They added naproxen.
Yes.
And the COX-2 selective with celecoxib.
Exactly.
So this one is quite important, and they have added the major adverse effect of this drug. So we already talked about it, and when using or not this drug. So they have described more in details each type of toxicity, like renal toxicity, cardiovascular, gastrointestinal toxicity, of course, elderly, breastfeeding, pregnant women. How you're going to use this drug, which category, which kind of drug medicine you can use. So first, you have to determine who is at risk.
Yeah, first, yeah, correct.
Simple thing.
That's very important.
Exactly. And then when you identify this risk category, then you're going to refer to table 2 plus the rest, what to prescribe.
Yeah. By the way, if you guys have any questions, in between, feel free to ask them. And Luisa have a question. Okay. So it says what you are mentioning is what's new, different to the old TG. Yes. Basically, we are trying to spot the things that weren't in old TG, so you guys know what new things you can add to your practical OSCE, basically. So yes, Luisa, we are trying to just fill the new things in there, because what it's already known by everyone, it's pretty much, I think TG is pretty much the same as old TG, but there are a couple of things that are new, and that's what we are trying to spot for you guys.
Then, after that, they are giving you some details, like which drug to use. One thing that they have added in the new TG is regarding opioid use. So the codeine is no longer recommended at all.
Yes.
Like Panadine Forte, I guess.
Yes. But I think we are getting ahead a little bit.
Yeah.
It's just because I interrupted you.
Yeah.
Because you were talking about what patients we shouldn't prescribe NSAIDs.
Yeah.
If we are dentists, according to the box number 8, they said that there are some patients who should not be prescribed an SAD by a dentist. So kidney impairment, heart failure, gastrointestinal ulcer or gastrointestinal bleeding, bleeding disorders, corticosteroids, anticoagulants, multiple risk factors for increased NSAID toxicity, such as elderly patients with a history of gastrointestinal bleeding.
I think this box is quite similar to the OTG,
Yeah, to the OTG.
as far as I remember.
I think that's pretty much it. And then, when you are choosing the analgesic regimen for a patient with increased risk of NSAID-related toxicity, in page 48, they describe pretty much, again, like what should be your critical thinking in order to prescribe or not an NSAID. Because if you are seeing the patient that we shouldn't be prescribing NSAIDs, that's a big group of patients,
Yes.
There's a lot of patients that have bleeding disorders. There's a lot of patients that have any gastrointestinal issues like ulcers or bleedings. So we need to be very careful when we have an OSCE related to a particular NSAID. So we know that we are doing our appropriate assessment for these patients.
Even they specify now here the pregnant woman not beyond 32 weeks.
Yes.
For instance.
No NSAIDs in there. Yes, and then what Rada was saying about opioid.
Yeah.
I think the most relevant thing that we found when we were reading this is that, yes, codeine is not longer recommended to treat dental pain.
They were, in OTG, there were a little chapter about codeine plus paracetamol.
Mm-hmm.
And they said that even if you give 60 milligram of codeine associated with paracetamol, it's not as efficient as a ibuprofen, for instance,
Yep.
or paracetamol alone.
Yep.
Also, there is some harms in prescribing opioids, so they don't want us to prescribe codeine anymore. So you can go for
Table 5.
Yeah.
Page 54.
So this is
that one.
That one.
Yes, table
Oxycodone.
5. Yes, they have put there the commonly used opioids in management of pain for dentistry, and they have oxycodone, tramadol, and tapentadol, and very highlighted no role in pain management for codeine. It says here that there is no good evidence that codeine is any more effective than paracetamol or NSAIDs to improve.
Abused.
Exactly, and has been abused in the past. So probably for you guys, that some of you that are working, as DAs or even practicing, if someone that is practicing is seeing us right now. So Benita, any particular indication for celecoxib? Celecoxib is a selective inhibitor of COX-2. So what you get from that one is that you don't get all the side effects that you get with ibuprofen or diclofenac or naproxen. So when you give this particular medication, basically you take away all the adverse effects. So in order to answer your question a little bit more in depth, Benita, if you have your TG with you, if you go to the part that is assessing which ones to, let me just get to that one. Here, for example, if we have a patient with increased risk of cardiovascular toxicity.
Page 48.
48. So it says, consider that ineffective pain relief can cause tachycardia, which may cause cardiovascular effects. So we need to control the pain for these patients. In this particular case, you can prescribe the celecoxib or even the ibuprofen, for example. So they are giving you here in UTG which are the indications for this particular one. For example, gastrointestinal toxicity. They recommend here using the COX-2 selective inhibitor, which is the celecoxib, because this one has lower gastrointestinal effects. With these ones, we are basically, we want to take away all those side effects that most of the other NSAID has, because they are not selective. They inhibit COX-1 plus COX-2. And COX-1 is the good one, the one that we have in our body and that we want to have. COX-2 is the one that it mediates, the inflammation and the pain as well. Okay, so Luisa says, I'm confused with page 49. It says to minimize harms in all patients prescribed short-term NSAIDs. I advise them to take them regularly rather than required. I do not understand the regularity they mean. What they mean is that the patient need to have pain management therapy, like with antibiotics. If you prescribe an antibiotic, you tell the patient take it 8 hourly for 5 days. They need to complete the regimen. For the patients, in order to be more successful in the control of the pain, you need to prescribe, let's say celecoxib, every 12 hours for 3 days. So the patient needs to take that the entire 3 days instead of when I have the pain. That's what they mean. Because not being effective controlling the pain can have adverse effects, for example, in patients with high risk of cardiovascular complications, because that can create tachycardia. So what they are saying is you prescribe in a therapeutic dose and the patient needs to stick to that plan.
Is that clear, Luisa?
And Benita asked about Oxycodone, and you put some interrogation marks in there. Is there anything that you want to know about Oxycodone, Benita? That's 54.
They said that it's the preferred opioid if you have a severe acute pain, because it has been widespread used. So we have, how we can say that, we can see if there was any side effect, or we can see back fewer drug interaction than tramadol. Tramadol is quite a tough one.
It's, yeah. And I'm wondering, in which cases, for example, like the cases, if we want to take this to an OSCE situation, I don't think there's any OSCE out there that we have seen that requires that we are going to prescribe the patient with Oxycodone or even tramadol, you know. We want to try to avoid those kind of things, because basically everything that is happening oral-wise,
fentanyl patch patient.
The drug seeker patient. Yeah. I mean, what we want to avoid is to do an overprescription for the patient, you know, because most of the dental pain that we get in daily basis, you can control it doing active dental treatment, you know. And if, let's say, you have surgical extraction of a third molar, if you have a very good surgical technique to minimize, you know, the possible pain afterwards, you know, if you minimize the time that you are in there doing the surgical approach and everything, I think we are not going to be needing to prescribe such strong analgesics to the patient.
We discussed that when we have a good active dental treatment, when we manage quite well, we really rarely need to prescribe opioids.
Yeah.
If it's an irreversible pulpitis, then we just start with our RCT.
Benita wants to know the indication and the brand name. Well, Benita, the indication for Oxycodone is pretty much what just Rada read. It's the first little box that you have in page 54 that says that is for severe acute nociceptive dental pain.
So she wants, we checked earlier, the brand name. You have Oxynorm, Endone, Proladone, Targin.
But you can even prescribe a generic one. So if you prescribe it, they should be able to offer the patient in the chemist either a commercial brand or even a generic one. It shouldn't be any difference for this particular one.
You can always write down, even you don't know the brand, just
exactly.
And in exam, we don't need to give brand names.
Yeah, they usually don't ask that.
No.
Although, having said that, you need to be prepared for everything, you know?
Yeah, we never know, but...
And there's ways to get around it. If you definitely don't know the brand name of Oxycodone, you can tell the patient, or in this case, the examiner, I'm not sure about these particular brands, but I know that the medicine that you need is Oxycodone, so I will prescribe you that, and probably you will have some alternative at the chemist just to choose for a commercial to a generic one. There's ways to get around things. It's just more about that your prescription is suitable for that particular patient.
Exactly. Hope it's clear. let's move on. If there is any question, don't
let's
hesitate.
keep going. Yep.
Topical corticos. Do you have finished?
I think so. Let me just. Yeah, I think that's pretty much everything that we have for acute dental pain. So the message is NSAIDs needs to be prescribed with caution. Refer to the table that says these patients are not suitable for NSAIDs. Do a risk assessment with the information that is in the subsequent pages. And take in mind that codeine is no longer acceptable for pain management in dentistry. I think that's pretty much what we need to remember. Yeah. Right?
The other change was about the topical antiseptics, page 60. Something new, cetylpyridinium chloride.
That's easy.
So that's a new one.
Imagine telling that to the patient.
Oh, they will understand, don't worry. It doesn't do any difference for them, it's just blah blah blah.
Yeah.
So you have several forms: mouthwash, lozenges, gargle. So basically you can use that.
So Dr. Dapesh is saying, and I think this is in regards to Benita's question, memes, that's a very good solution. And thank you, Dr. Dapesh, for mentioning that, because remember in Urosky stations you will have a meme. Memes. And next to you, you will have the memes that you can use during the 3 minutes reading time. It's not for you to use during the 10 minutes of the role play. But at least when you read the case and you think, oh, maybe this patient will need Oxycodone because, I don't know, maybe the case warrants that need, then you can, refer to memes in order to prescribe that to the patient.
Do you remember in the exam the medical form that they provided during the OSCE? I remember that it was not any brand name, it was the name of the medication itself.
I got one case and no. What's the brand name of that bisphosphonate?
I had like this case with the patient with the dry mouth and stuff, and she had several medication that could cause dry mouth. And
I think they give generic names.
Yeah,
you're right.
Generic name.
Yeah,
it was not the brand name. So I mean, we never know. We can't tell you 100% you won't have any brand name, but as far as I remember, it was only the generic.
Yeah, and the advice again is not to panic.
Yeah.
Just because you don't know a brand name, that doesn't mean that you are going to fail your OSCE. You can tell that the same way that you will tell it to a patient in real life. If the patient tells you, oh, do you have any commercial names? And you say, oh, well, I have nothing in mind, but if you ask in the chemist, they will tell you, It's not about being frozen in the moment, like, oh my God, I need to know this, otherwise I'm going to fail. It's not about that. There's ways around it, and if you are resourceful enough, probably you are going to be okay.
It says also, do they talk about the mouthwashes containing essential oils in the OTG?
Yes. No, we have that one.
So triclosan no longer
Triclosan is no longer recommended. We also found out today that Colgate removed triclosan for their toothpastes because apparently it's widely absorbed.
They found out that the body is highly absorbing this molecule. So they found a high proportion in the breast milk, in the urine. So they are not sure about the consequences, if it can, for instance, cause cancer or genetic mutations, stuff like that, but just in case they removed it.
Oh, thank you, Joyce. Yes. They gave for this bisphosphonate Prolia, that's a commercial name, and they mentioned that in one OSCE. That's right, that's why you also have the memes next to you, because they are not expecting of you to remember all these names.
Yes.
So thank you so much, Joyce, for refreshing my mind. That was a name, which is pretty much denosumab. That we, bless you.
Thanks.
Oh my God.
I'm good, don't worry.
Coronavirus? No? Okay.
That's it.
That's pretty much it. So basically, for the mouthwashes, the changes are that triclosan is no longer recommended. Not that we prescribe that thing, but just for you to have it in mind.
Now we go with the acute odontogenic infection.
Yeah, okay, so yes, guys, so this is basically for management of pain. If you have any questions regarding this subject, please let us know. In the meantime, I think we can move to
page 79.
Exactly, to see what's new or different for acute odontogenic infections.
Yes. So what we spotted is that
this one, remember?
Yes, the antibiotic therapy is not a substitute for dental treatment. The thing that is new is that if you can't provide a dental treatment within 24 hours, you can give antibiotics to the patient. So, for instance, we have that patient that is uncontrolled diabetic, he has an infection, and because we can't provide him a active treatment because he's immunocompromised and has a swelling, so spreading odontogenic infection, then you can give him antibiotics without doing the active dental treatment, like we are talking about a particular scenario, like you have to extract that tooth. So the time he goes to the hospital to get that tooth removed, you can prescribe him the antibiotics, provided he sees the medical team and the practitioner that will remove this tooth within 24 hours.
Yes.
So that is a change, because in the old TG, it was no
source of many debates. And when we have conducted courses here, I do remember discussing lengthily with candidates about if we can prescribe an antibiotic without doing the active dental treatment, because in the old TG it wasn't that clear.
Yes.
Old TG was like, you have to provide active dental treatment at all costs.
Yes.
But we know that if a patient is severely immunocompromised, doesn't work that way. So I think this particular paragraph that you see here is quite important, but what Rada said is, I think, even more important, and is to apply that to the context. It's not that they are opening the door for you to prescribe things without treating patients.
Yeah, just I don't want to see you today. It's I don't know. It's Saturday night evening.
Yeah.
Everything is about to close. You really can't do something to the patient.
Yeah.
You can prescribe antibiotics and then see the patient within 24 hours or Monday morning, early morning to do something for the patient. It depends on the situation.
It depends on the context. And I think we have also spoken about this a lot of times, that you need to be aware of the context. There is no set way to answer a particular OSCE scenario.
Exactly.
Depends on your criteria, depends on your assessment. So you need to apply common sense to these things as well.
Yeah. So the table 9, page 80.
Yep.
So they give you clearly like all the categories of infection. So you have 3 categories of infection, the clinical features, and they give you the management, and it's really,
which is super good.
Exactly, it's clear.
It's clear.
No confusion. No doubts. Straightforward.
This is pretty much. I mean, if you get a case of infection that you have in your armamentarium of OSCEs, you just need to go through this little table, classify the patient in one of these 3 boxes,
clinical features,
and apply. you know, and consider comorbidities.
Yeah.
Just for you to know if you need to tweak a little bit your management, like in the case of the uncontrolled diabetic patient. So I think this is quite important because those clinical features are also very useful in order for you to do history taking. So if you know, or because let's be honest, when you see an OSCE case, you know what the OSCE case is about. I mean, you are a dentist. So what you need to do is to perform like you don't know what is going on, and then you are going to ask questions that are relevant for that thing that you have in mind. So if you know that a localized odontogenic infection is going to be no facial swelling, no severe systemic features of infection, then you rule out. Do you have fever? Do you have difficulty breathing? Do you have difficulty opening? You know?
Then you know.
Then you know. You are confirming. So these clinical features also give you hints on which questions you can ask, so the examiner can tell that you know what you are talking about.
And you're taking all the clinical features, so okay, this corresponds to that particular situation, then I'm going to do this management.
Yeah, correct. So this box is quite useful.
Exactly. So then they have...
so what they have done after that is that these have this little table that it tells you that your patient can be classified in 3 different types of infection. Localized, spreading with no systemic features, and spreading with severe systemic features. So you have these 3 patients. And they are going to go into more detail about the management for these particular 3.
Yeah. So what is different about the prescription of the antibiotics is now, when you have spreading odontogenic infection without severe or systemic features, before you had to give penicillin, so either phenoxymethyl penicillin or amoxicillin. And if it is not responding well, if it's very severe, then you add metronidazole.
Yep.
Now you have to give metronidazole plus either phenoxymethyl penicillin or amoxicillin. So it's not in case of unresponsive situation or severe situation or immunocompromised. It's both. Straightforward.
Yes. And look, in the old TG, they said for spreading odontogenic infections that didn't have the systemic features, they were telling you to consider antibiotics. Here, if you go to the 3 bullet points that outline the management, they said that you need to, the management is going to involve drainage, surgical treatment or dental, which is the active dental treatment, and oral antibiotic therapy. So here, we don't have to debate.
Yeah.
Should I
have to start?
Exactly. Should I prescribe? Shouldn't I prescribe? You know that you are going to prescribe for these cases.
And it's written clearly on the first paragraph.
Yep.
Once the source of infection has been addressed, start
Antibiotic therapy.
One thing that they added again is that they recognize, they acknowledge that when you have an infection, the local anesthesia may not work efficiently, well. When in old TG it was written that
was not true, something
not
like
true,
yes.
And it's efficient.
Yeah, but still it's not a reason to delay the treatment.
Of course.
Yeah.
So, but it's good to acknowledge the real life.
Exactly, because that's also something that you can communicate to your patient. So if the patient has a spreading odontogenic infection that you are going to treat by removing the tooth, let's say, you know that sometimes that acidic environment that provides the infection can make that some parts of the tooth resist to the to the anesthetic. So you can communicate that in your role play. You know, like I will do my best to try to numb the area properly. Bear in mind that if some, parts of the tooth are resisting to the numbing, I will, top up the anesthetic. Ways around it, because it says here that can happen, and for everyone that practice, we know that
it
happens. Yeah.
What else?
What else do we have there? Okay, and yes, I think that's pretty much for the
I think.
So just to summarize, localized odontogenic infections, no need for antibiotic, just dental treatment. That's it.
Localized dental.
Exactly. When it's spreading without severe systemic fissures, dental treatment plus antibiotic therapy in the new formulation, which is metronidazole plus phenoxymethylpenicillin or the amoxicillin, straight away. And if we are having a spreading odontogenic infection with severe or systemic fissures, that also include Ludwig angina, that warrants immediate referral, because
the hospital.
The antibiotic therapy here is only
IV.
Yeah. So that's out of our scope, I reckon.
Exactly. And again, they are prescribing benzyl penicillin, IV, plus metronidazole.
Yeah. So basically what they are saying here in this spreading odontogenic infection with severe or systemic fissures is arrange urgent transfer of patients with a spreading infection with severe systemic fissures to a hospital that has an oral and maxillofacial surgeon or another appropriate expert.
I think the rest is quite similar. Now the infection following dental alveolar surgery. So the thing is a little bit different from the odontogenic infection. The beginning is the same as OTG. Then again, you have to ask if there is severe symptoms like significant facial swelling, if there is a trismus, any difficulty in breathing, swallowing, the elevation of the tongue. So when it's not severe, drainage, removal of the source of infection, and rehydration and analgesia, like the OTG. And if it's severe, or if the patient is immunocompromised, then you give the antibiotics to the patient plus the dental treatment.
Yeah, they say here, in this one, they pretty much take what the OTG says that consider using antibiotic therapy. So your clinical criteria is going to be very important there, because unlike like the spreading odontogenic infection without severe symptoms that they are saying that's a no-brainer, prescribe the antibiotic, for infections following dental alveolar surgery, they are suggesting you to consider the antibiotic therapy, which is not necessarily compulsory in this case, but there is when your clinical criteria comes into play. So you are able to explain that to the examiner in a particular OSCE case. And the review of the patient every 48 to 72 hours, that we already know. And if after that dental alveolar surgery, if the patient has an infection and you treat that patient for that infection and within 5 days you haven't seen any improvement, then you need to obviously refer the patient, I think, to a hospital.
For that,
yeah,
just like the
OTG. Yeah. And I think that's pretty much right, Rada, regarding acute odontogenic infections.
Exactly.
Okay, so in the OTG, we used to have acute odontogenic and salivary gland infections together in one chapter. In UTG, they decided to give an entire chapter to salivary gland infections here. So we are now going to discuss what is new regarding salivary gland infections, because there's quite a bit pages here.
Basically, in this chapter, in the OTG, you could give the antibiotics to the patient. And now the difference is that if the patient has an acute suppurative infection of the salivary glands, you have to do an urgent referral to the hospital for surgical review, and then they will manage.
Yeah, that's true.
So urgent referral to hospital, and then they will give the antibiotics intravenously, so IV.
And in the box 11, which is page 90, they give you potential causes of salivary gland swelling. So we were talking also earlier about how your clinical judgment is quite important here, because yes, we can spot signs of infections, but that infection can come from a tooth or can come from a salivary gland, like in this case. So when you are asking the history to the patient, you need to include tests, you know?
So
cold, percussion.
yeah, exactly. You have to eliminate any dental cause. You have to tell the patient, first, I would like to make sure that I'm not missing a dental problem. So I'm going to do some tests to these teeth, depending on the region. And then you are going to investigate more about this salivary gland, palpation, try to drain some pus from the orifice of the gland, and so on.
Yeah. So when you revise the possible causes for salivary gland swelling, you have here inflammatory causes. We know that is very common, Staphylococcus aureus infection for salivary glands, viral infections, mumps, Epstein-Barr.
And this we learned it with the part 1.
Yes. Chronic
remember,
infections, autoimmune disease such as Sjögren's syndrome, because we know it affects the glands.
Yeah.
And then you can have obstructive causes like stones, trauma, granulas, metabolic causes, obesity, hypothyroidism, alcoholic liver disease, malnutrition, and tumors as well, and some drug or food hypersensitivity. So they have included quite a little bit of information in this new TG. So it only makes you wonder, are they going to prepare a case regarding this, because we have new information, so you need to be prepared in order to do a correct differential diagnosis.
Exactly.
And regarding the therapy, it's pretty much straight to the hospital and intravenous if it's acute, obviously. And
so for me, as a OSCE scenario, what can make a little difference is that you are going to investigate about a dental origin. So they will see if you are doing a differential diagnosis or not.
Yeah, which is quite important, because it happens a lot that since we are dentists, we think always that this is a tooth or a teeth or some teeth, that are creating something in there. But before jumping into a conclusion straight away that the infection is coming from a tooth, you need to rule out possible things in there. So I think, again, critical thinking, common sense.
Very important.
Very important in these cases.
Ask questions if you feel that something is missing in the information that they are providing. And then, you're a dentist, so
the most important thing is, for example, with salivary gland infections, we already know that this is not something that we are going to treat, obviously, it's going to refer, but if we do the correct course of treatment to the patient, the correct advice, that's very, very valuable.
So it helps us to reach accurate and precise diagnosis. And then we can know how to manage that patient, and then refer, like if it's salivary gland, or if it's a odontogenic origin, then we are going to manage that.
Yeah. And I think this is what we had prepared for you guys today. Yeah. Any questions? Something that is not clear for you? Again, this is an exercise that we are doing just to try to gain more information about how to apply these things to your real OSCE scenarios. And this is pretty much the first of several sessions. A series of sessions that we have for TG, old TG versus new TG.
Hope it's useful. If you have any question, please feel free to leave us a comment.
Which specialist? So Benita, which specialist? Okay.
Oromaxillofacial surgeon.
Regarding which condition? Because it is mentioned to refer to in salivary gland infections. Oral and maxillofacial surgeons. Yeah, that will be the specialist. Yeah.
Or they acknowledge also the difficulty for rural areas to maybe get a specialist. So any expert, because here they are writing down, seek expert advice. Any expert could fit, could match. So. All right.
You're welcome, Dr. Dapesh. You're welcome, Kirti. Thank you guys for watching us. Yeah, for keeping up with us. We are just trying to be around,
easier.
And give useful information, and to keep connecting with you guys because we know that it's very, very easy to lose track of your process when everything is on hold. But as always, we encourage you to keep on track, keep on practicing, keep on studying. That's quite important.
So oral med as well.
Oral med as well, according
That's
to the
why
patient.
expert specialist is.
Yes, yeah.
All right, thanks very much, guys. We see you next time, and have a great day or evening, depending where you
The time
are.
zone.
See you. Bye-bye.
Bye.